the BLAST trial is unique because it is the first time that we had a primary endpoint conversion of MRD positive to MRD negative. So the first time the regulatory agencies, both in the US as well as in Europe, have accepted a primary endpoint based on MRD testing. Recognizing this endpoint is pivotal for us because looking at other disease settings in hematology at least, it is very clear that MRD is very important. It's going to be an endpoint for other disease settings. So this trial really has pioneered the awareness within our society, hematology field, but also with regulatory agencies, that there is something beyond complete remission, beyond OS or PFS, anything like that. We have now MRD established as a way. So I think apart from the clinical benefit that it has and the unique mechanism of action, this is really also in my mind a key result, outcome for us hematologists. Anyone who remains MRD positive after consolidation 1 is chemorefractory. So it is a key decision point in making the decision to continue therapy with standard therapy, chemotherapy, maintenance therapy, etc., or to branch off to give the patient blinatumomab transplant, an elderly patient just blina. Similarly, if a patient becomes again MRD negative during consolidation, maintenance, or after that in the observation period, also would change the way how we treat the patient. So we'd stop consultation straight away if the patient becomes again MRD positive during consultation. The same for maintenance therapy. If he's maintenance therapy and he becomes MRD positive during that period of maintenance therapy, we stop it straight away, switch over, and expose the patient to blinatumomab, then sequentially a transplantation. And similarly, in the observation period, very similar sequence, you would at least offer them blinatumomab in that context and potentially also take them to transplant. So it is every time MRD positive is or negativity is going to decipher either you stay on track what you've been doing, and if you're MRD positive, you have to do something different. Because once you're MRD positive, 95% of your patients, despite continuing therapy, will be relapsing with full-blown relapse, and then you are in a much more uncomfortable situation. You catch a bird much earlier, you have a very high response rate, and just bearing in mind that blinatumomab is also licensed for relapse refractory ALL, so full-blown relapse. Response rates they are lower, they're just 43–44%. And also looking at those patient population, looking at patients with high tumor burden and low tumor burden, the ones with even high tumor burden, which is the majority of them, it's only just 30% which have a response rate. So it's very obvious, early, catch a bird early, 80% response rate versus on the deep end side in only just 30% response rates once the patients really develop a full-blown relapse with 80% blast count in the bone marrow. Maintenance therapy we will offer to every patient, irrespective of age. And we try to get away with that by looking at a particularly favorable patient population who had become MRD negative very early onwards after and then remained MRD negative for 1 year. And then we asked the question, can we take away MRD maintenance therapy for these patients, these MRD negative patients? But unfortunately what happened is that there was a higher relapse rate. So MRD testing is great, it really detects, but it's not the whole story. because if you look at it, MRD is only a reduction of maybe 5 to 6 logs of tumor burden. So, but the patient, when he enters the arena, presents himself with 1 × 10⁻12 leukemic cells. So if you reduce by 6 logs and then you're below the detection range, you still have a huge space to cover. And we don't know what's happening down there. So maintenance therapy is absolutely necessary for leukemia patients, in ALL at least.